Welcome and thank you for joining the 2021 Houston Area Parkinson's Society Summer Lecture Series June session. I'm Kathleen Christ, Executive Director of HAPS. Since 1974, HAPS has been the only organization in the area providing comprehensive services to the local Parkinson's community. Our mission remains the same since we started, to ensure that no one faces a Parkinson's diagnosis alone. I'm excited to welcome you to the first session of the 11th Annual HAPS Summer Lecture Series. Last year, we moved this program to a virtual platform, and at the time, I would not have guessed that this series would again be hosted online. However, due to ongoing considerations related to COVID-19, we decided to keep our educational programs virtual and are looking forward to bringing everyone together in large-scale events later on this year. If you're familiar with this educational event, you know that our summer lecture series is an opportunity to provide serious educational content in a relaxed environment with a fun summer theme. Despite continuing with the virtual platform, we've decided to commit to the theme, and while it may lose some of its effect for those of you at home, here at the HAPS office, we are enjoying the summer fun. Before we get started, I have several groups that I would like to thank. First, I want to thank all of those who make up our board of advisors, and medical advisory board for their ongoing support and the role they play in developing and implementing our programs. I want to thank all of the members of the HAPS team for the efforts and the energy they put into every program and event that HAPS offers. I also want to thank our sponsors. During a time when funding is critical and hard to come by, this group has remained steadfast in their commitment to our local Parkinson's group and to helping us ensure continuation of our mission. We remain grateful for their generous support, and we are proud to consider them partners in the work that we do. Specifically, I want to thank our presenting partner, Supernus, as well as AbbVie, Boston Scientific, UCB, Amneal, Home Instead Senior Care, Medtronic, Synovian, and Acadia. Additionally, I want to thank our Parkinson's community for joining us today and for staying involved in all we have offered through the years, but especially over the last year as we've navigated this pandemic together. And finally, I want to thank our presenters for sharing their time and expertise today, helping us gain better understanding of the disease and for getting us up and moving after the lecture. Quickly, I want to give you a rundown of today. You'll hear from our speaker, Dr. Jaskaren Dhillon, who will then join me for a question and answer session after the presentation is finished and before we join Rita Upadhyaya for her exciting movement lab featuring yoga. If you do not already have the handouts for today, you can access them on the HAPS website at hapsonline.org under the Summer Lecture Series section, or by clicking the link sent in the email that contained the link to today's webinar. This is the email sent by HAPS, not the email sent by Zoom. The program includes full presenter bios, upcoming HAPS events and programs, information from our sponsors, and the presentation for today's lecture. There will be a couple of brief breaks while we set up for the question and answer portion of the program and as we go to our movement lab studio. So I thank you in advance for your patience with this process. During the question and answer session, we will be addressing questions that the audience submits throughout the course of today's lecture. If you're participating in the live session, you have the option to submit questions through the Q&A feature at the bottom of your screen. We will only be monitoring the Q&A option and will not be monitoring the chat or the raise your hand feature during today's program. At this time, I would like to introduce our speaker of the day. Dr. Jaskaren Dhillon is a movement disorder specialist at Houston Methodist Willowbrook Neuroscience Center. She completed her neurology residency and her fellowship training locally at McGovern Medical School at UT Health Houston. Her primary areas of interest in movement disorders includes Parkinson's disease, atypical Parkinsonism, tremor, dystonia, ataxia, and others. Dr. Dhillon is board certified in psychiatry and neurology. She is well published, and this is how she describes her approach to practice. As an advocate for patient education and clear communication, I strive to collaborate with my patients to create personalized management plan. The ultimate goal is always focused on the path to recovery and health. Welcome, Dr. Dhillon.
Thank you, Kathleen. Before I begin, I wanted to say thank you to the HAPS community for allowing me to kind of be a part of today. And you guys know that today we're talking about sleep issues and Parkinson's disease. So majority of you guys tuning in either know somebody with Parkinson's disease or suffer from it yourself and have sleep issues. So I hope this will enlighten us or maybe bring about questions we may come up with our healthcare providers. So currently, I am at Houston Methodist at Willowbrook. So our first slide, what is sleep? So sleep is a naturally reoccurring state characterized by reduced or absent consciousness. We spend approximately 1/3 of our life in the sleep state. So it's very critical that we get good sleep. It's an anabolic state, important for energy conservation. It's essential for energy restoration, immunity, learning, growth, and development. There's some evidence out there that it also helps with clearing waste products from the brain. Lack of sleep can lead to poor physical and cognitive performance. So as we know, it's not just whether you're awake or sleep. Sleep is divided into two broad categories of REM and non-REM. REM meaning rapid eye movement. Non-REM when it's not rapid eye movement. So the first kind of state that we go into when we fall asleep is non-REM sleep. It's further divided into 4 stages. Stage 1 is a transitional state. It's drowsiness is another name for it. Might still be aware of your environment, noises, easily arousable. Stage 2, heart rate tends to drop, muscle activity calms, body temperature drops. So it's more of a calming, relaxing state. Stage 3 and 4 collectively together is called slow wave sleep. In it, the blood pressure, heart rate, body temperature at its lowest through the cycle. REM sleep, rapid eye movement sleep, its eyes move rapidly, heart rate increases, breathing increases. So it's usually associated with dreams, your mind's awake, but your body's asleep and your body is paralyzed. It's called REM atonia. So this is a normal sleep hypnogram. In it, as a 7 to 8 hour normal sleep, we have different sleep cycles. So meaning that there's cycles that are 90 to 120 minutes. So it's about 5 to 6 sleep cycles in a night's period. It's color coded. So the green is REM sleep. The pink and dark red is non-REM sleep. So the first half of the night is mostly non-REM, slow wave sleep, a deeper level of consciousness. And then through the second half of our sleep, we have more of a REM state. So more of that dreamlike state. As you can see, kind of as deeper down we go, it's more decreased level of consciousness, more wakefulness towards the top. The cycles do tend to get shorter a little bit throughout the night. This is it's called an EEG. So it's when we've studied sleep, the different states. So wake sleep, we can see that it's characterized by a different EEG pattern. And I kind of wanted to go over this because can see the similarity between REM and kind of the wakeful state where the brain's a little bit more active. Stage 3 and 4, the reason why it's called slow wave sleep is because of the EEG characteristics. Circadian rhythm is important to understand for sleep cycles. It's the physical, mental, and behavioral changes that follow a roughly 24-hour cycle. It responds primarily to light and darkness in our environment. So that's why when it's light or bright outside, we're more awake, and when it tends to be dark, we tend to be more sleepy. It affects not just our sleep, but also our temperature, blood pressure, heart rate, and hormone secretion. The kind of you can say control of it is a suprachiasmatic nucleus, which inputs from different parts of our body, most commonly through our eyes, and it signals the pineal gland to secrete melatonin. Melatonin tends to rise towards the end of the day, remain high throughout the night, and drops early in the morning. The higher the melatonin level, usually the more sleepier or in sleep we are. This is a diagrammatic presentation. So the retina, through stimulation of light and via dopamine as a neurotransmitter, transmits to the suprachiasmatic nucleus, which through cycles into the pineal gland, the purple circle in the diagram that then secretes melatonin. This is also a pictorial diagram of the melatonin level. I can see that throughout the day, it kind of rises at 8 p.m. as the sun sets, and then throughout the night it peaks and then starts to kind of lower down as sun rises. This is another I'm very visual, so I think these help. So the inputs for the circadian rhythm, lights, eating schedules, exercise. So this can all affect our circadian rhythm, and our outputs. So how it affects us. It affects our sleep-wake cycle, our cognitive performance, heart, muscle, liver, and kidney function, which then has an effect on our behavior and our physiology. Sleep tends to change as we age. It's not, you guys all know that as we're babies or teenagers, it's not the same as when we're 50 or 60. So what are some of this normal, I guess, sleep changes that we see with aging? We tend to get sleepier earlier in the evening. We fall asleep and wake up earlier. There's increased nocturnal awakenings or arousals, deep sleep, non-REM stage 3 and 4, so our slow wave sleep decreases, and our light sleep stage 1 and 2 kind of dominates throughout the night. And this is another pictorial diagram to kind of show the number of hours of sleep that is on average as we age. You can see that it's kind of the highest at birth and tends to decrease as we get closer to the age of 100. And how does sleep change as we age? So not only is it the hours of sleep that decreases, but also as we go from infancy to old age, we see that we're awake more often. REM kind of decreases as we age, and non-REM, although tends to increase, it's also more fragmented with wake states in between. So how does PD further affect the sleep architecture? So we know that the neurodegenerative process that's affected in Parkinson's also affects the sleep regulating brain centers and circuits. Melatonin production decreases in patients with PD. Dopamine, which is stimulated by the light signaling on the retina, also decreases. So not only does kind of aging affect the same things on the sleep cycle, so does PD. So we also see increased frequency of nocturnal arousals, reduction in total slow wave sleep, so stage 3 and 4. There's reduction in REM sleep as well. Sleep disorders, unfortunately, increase with the duration and progression of Parkinson's, and chronic sleep-wake cycle disturbances are a risk factor for hallucinations. So today's presentation will kind of go off, this is kind of a itinerary of the topics we'll be discussing today. So insomnia, nocturnal off, restless leg syndrome, abbreviated as RLS, REM behavioral disorder, abbreviated as RBD, sleep apnea, urinary issues that can lead to disturbed sleep, depression, anxiety, akathisia, daytime somnolence, nighttime hallucination, psychosis, and confusion leading to disturbed sleep, and then poor sleep hygiene in general. So you don't have to worry about waking up in the middle of the night if you don't fall asleep to begin with. Insomnia, trouble falling asleep and staying asleep, as well as waking up too early. So these are kind of, if a patient complains of this, we think of insomnia. 30% of patients, those without Parkinson's, have insomnia, and this increases as we age. This is insomnia is higher prevalence in patients with Parkinson's, and as we discussed, worsens as disease progresses. So when I ask my patients, what time do you go to sleep? Usually they'll be like, oh, I go to sleep at 8, but I have a hard time falling asleep. So I kind of try to differentiate what time you get into bed versus what time do you actually fall asleep. Sometimes it's kind of hard for a patient to differentiate the two. So also clinically, we have to differentiate if insomnia is acute, episodic, or chronic. Acute, usually there's other things contributing to insomnia, and usually is not related to something such as sleep hygiene. Parkinson's patients usually do not have trouble falling asleep, but have multiple nocturnal awakenings with difficulty falling back asleep throughout the night. So patients with Parkinson's who have insomnia are seen more common in women, advanced PD, and if there are also comorbidities, other medical and psychiatric conditions. Management. When discussing insomnia with the healthcare provider, we'll usually go over the sleep hygiene, rule out any other sleep issues which may be contributing to insomnia, review medications as well as medical conditions. We'll sometimes help for cognitive behavioral therapy. Light therapy is also shown to help if increased exposure to light, certain types of lights during the day, and as we dim throughout the night, through the evening to night, it's shown to help with insomnia. Sleep aids in the form of medications, sometimes over the counter, can assist. Commonly asked to count sheep before you fall asleep. So when sheep can't sleep at night, do they count us? Nocturnal off, when medications used to treat PD have worn off at night. It particularly are seen in patients who are immediate release formulations. So the medications aren't, the dopamine levels throughout the night are lower. And so there's reemergence of severe tremors or rigidity, difficulty turning in bed, difficulty getting up and out of bed, and may even require assistance, which usually is not seen during the day. Patients may complain of painful off dystonia, or even nocturia is seen during nocturnal off. Certain management, satin silk sheets or pajamas, I think that's more to help with turning and kind of being able to, when we're not able to physically get out, as well as discussing with our health care provider about optimizing medications, usually in the form of long-acting carbidopa-levodopa or an addition of entacapone. Restless leg syndrome is commonly seen in patients with Parkinson's. We ask for 4 cardinal symptoms. So this is more of a subjective complaint. In it, the patient usually complains about, hey, there's an urge to move my legs. I have to move my legs. And as soon as I stop moving them, my symptoms return. So rest induces symptoms, and getting active brings relief. It's worse in the evening and at night. Sometimes this sensation, it's described differently in different patients. Some patients report as an uncomfortable, unpleasant feeling. Most commonly, I've heard a creepy crawly sensation. Some patients may describe as a throbbing aching or water running down their legs. One of the cardinal symptoms is when we stop moving around, the symptoms return. So it's hard to actually get that restful state prior to initiating sleep. So it's important to differentiate this from periodic limb movements at sleep, which we'll talk about later, as well as akathisia. This can lead to insomnia, difficulty falling asleep, because we're constantly wanting to get up and stretch and move our legs. Some of the screeners or associations is a family history of RLS. Can be seen autosomal dominant, neuropathy, iron deficiency, chronic renal failure, thyroid conditions, pregnancy, and certain medications. So the treatment, if we checking blood work and we find that there is an iron deficiency, we'll go ahead and supplement with iron. Maybe even refer to a hematologist to figure out why there's an iron deficiency. Dopamine agonists or levodopa, however, long-term, run the risk of augmentation. So that means that usually your symptoms begin at 7 p.m. You may notice that with long-term use of dopamine agonists or levodopa, initially you'll have kind of symptom relief, but then as time goes on, you may notice that your symptoms begin earlier in the night, may even progress to more proximally, so kind of upper in our legs, or may even go into our arms. Some patients notice that gabapentin helps. Sometimes we need the help of pain medications such as narcotics. What are periodic limb movements as sleep? So these are periodic episodes of repetitive stereotype limb movements during sleep. Usually it's not a complaint of the patient themselves. Usually it's a bed partner reporting that their legs jerking, and usually does not lead to nocturnal arousal. So sometimes it does not require any treatment unless there's injury or affecting your sleep as well. Is diagnosed usually during a sleep study when movements of a limb, so usually the legs, but can also occur in the arms, about 15 per hour. It's seen in correlation with RLS, so 80% of patients with RLS have periodic limb movements of sleep, but most patients with periodic limb movements of sleep do not have RLS. So these can be a simple movement such as a jerk, or a complex movement like twisting or turning. Can be in one or both legs or even the limbs, hence limb movements, not leg movements. Treatments, if treatment is required, it's responsive usually to gabapentin. REM behavioral disorder. Usually, if you for initial when you initially go to a neurologist, there's complaints of possibly diagnosis of Parkinson's. Last, do you act out your dreams? Dream reenactment or acting out dreams is kind of a layman's way of asking for REM behavioral disorder. We know that it predates Parkinson's diagnosis by many years or even decades. It's present in 60% of patients with Parkinson's. It's also associated with alpha-synucleinopathies, other alpha-synucleinopathies such as MSA or LBD. Unfortunately, it appears to be a predictor that patients with Parkinson's will have more severe cognitive decline as the disease progresses. And why do we have REM behavioral disorder? So remember that in REM, our our mind's awake and dreaming, but our body should be paralyzed. There's loss of the reticulospinal inhibition that occurs. So that inhibition of our muscles to be relaxed and paralyzed, that's lost. And we tend to act out our dreams. Usually these dreams are violent in the form of fights, running away from something. Usually they're not very pleasant. The patient is unaware. A bed or room partner is aware. Sometimes patients who sleep alone may wake up with injuries to themselves. And so unfortunately, it also increases in frequency as time progresses in Parkinson's. Sleep studies are sometimes needed to rule out any other confounding diagnosis. Pseudo RBD can be seen in obstructive sleep apnea as well. It's diagnosed during a sleep study when there's excessive muscle or motor activity during REM sleep. So it's loss of that muscle atonia. So treat if bothersome. Sleep environment changes may be needed. Lowering the mattress to floor level, making sure there's no sharp like bed corners, bedside tables, ensuring that the bed isn't close to a window, as well as melatonin, which is available over the counter in the form of usually 3 to 15 milligrams, maybe 30 minutes before bedtime, sometimes taken at sundown. Clonazepam sometimes is needed, usually kind of a low, medium dose can help patients' symptoms. Sleep apnea. So this is characterized when breathing is repeatedly interrupted during sleep. Sleep apnea leads to a decrease in blood oxygen levels, causing a patient's blood pressure to rise and heart rate to slow. So usually it's associated with some awakening. Sometimes there are microarousals and the patient doesn't even recall being awakened. And sometimes a patient, usually the bed partner will notice that the patient stops breathing and like gasps for air. Sleep apnea is further obstructive versus central. Majority of our patients have obstructive sleep apnea, so closing of the airway impeding airflow. Central sleep apnea, fortunately, is not very commonly seen in our patients. The narrow input for respiratory drive is absent and treated a little bit differently. So obstructive sleep apnea, the diagram on the left shows kind of the normal airflow through sleep. Majority of us are nose breathers, so you see that the air kind of goes from our nostrils into our nasal cavities, nasopharynx, and down into our trachea and lungs. In sleep apnea, you see how the tongue kind of obstructs. The soft palate has then moved a little bit back and enclosing the back of the throat, hence impeding that kind of airflow into our trachea and our lungs. So what are some of the symptoms of sleep apnea? Loud snoring, gasping or choking after a pause while snoring, sleep fragmentation, morning headaches, dry mouth upon awakening, daytime sleepiness, difficulties with concentration or overall mental functioning. Sleep apnea not only leads to poor sleep, but also increases our risk of higher blood pressure, heart arrhythmias, heart attacks, strokes, and type 2 diabetes mellitus. Diagnosis, a sleep study is usually needed. It can either be performed in a sleep lab versus home nowadays. Sometimes 2 nights are needed. First night is usually to diagnose sleep apnea, and the second night is to titrate in case we opt to have kind of a CPAP device, which I'll discuss later, titration of the appropriate pressures. So what to expect during a sleep study. So yes, we tried in the sleep lab, we tried to kind of imitate normal sleep as best as possible, but you will likely be plugged up to a lot of machines and apparatuses. One is a pulse oximeter, so measuring your blood oxygen level, breathing belt that kind of goes around your torso to see how your body inhales and exhales, airflow detector, as well as a heart rate and an EEG, so kind of the stickers over your head to kind of look at brainwave activity to see what stage of sleep you are in. What is the treatment of sleep apnea? Weight loss. However, majority of patients with Parkinson's with sleep apnea aren't necessarily overweight. Medication adjustments. This is rarely seen if associated with off symptoms, so there's not adequate chest wall rise because of rigidity. You may require some supplementation of levodopa or dopamine. Devices, which we'll talk about. So sleep apnea, the most common treatment is CPAP. So administering a continuous positive airway pressure to ensure that the muscles and the soft tissues of the nasopharynx, the tongue, the palate, the back of the throat kind of remain open, so airflow is not impeded. So there's different types of devices, some that cover just our nose, some that cover our nose and our mouth, and some that is just impeding airflow because of the closing of the nostrils and the upper the nose. And so there's that device with the female on the bottom, which just opens that cavity. So laugh and the world laughs with you. Snore and you sleep alone. Daytime somnolence. So this can also be seen in early PD. It's usually multifactorial and related to insomnia. Daytime somnolence can be severe and can be associated with sleep attacks, which may be an indicator of medication side effect as well as disease progression. So multifactorial. So other sleep disorders can lead to daytime somnolence. As we're not getting adequate sleep at night, we're kind of compensating it for falling asleep easier during the day. Certain medications, medical or mental health, and changes in the brain as we age. So we had discussed that earlier. Diagnosis, there are some sleep scales available that we may use to have a questionnaire. Sometimes a sleep medicine referral is needed for a sleep study, and sometimes during the day with the multiple sleep latency test. Treatment of contributing factors, light therapy, so exposure to not just daytime sunlight, but sometimes light therapy in the form of blue ray can help with daytime somnolence and remaining that wakefulness. I also recommend that patients try to stay as active as they can during the day. Sometimes, unfortunately, we do have to respond to or prescribe wakefulness promoting medications, such as caffeine, Provigil, Nuvigil, or Ritalin. Depression and anxiety, how does this affect sleep? So it's usually difficulty falling asleep, turning the brain off. Depression and anxiety can also lead to shortened REM sleep latency. So we see REM earlier on during the night. Increased arousals, early morning awakenings with inability to fall back asleep. Usually responds well to medications, cognitive behavioral therapy. Akathisia is a subjective complaint. Patient usually reports of inner restlessness. And this can be due to a number of reasons, but so one of the things we look at is low dopamine state or the wearing off. So it can be associated with the nocturnal off symptoms as well. Anxiety, depression, and a number of stimulant medications can also lead to this feeling of akathisia. So nocturnal urinary problems can indirectly lead to sleep issues, kind of maintaining that restful sleep, having to get up and go to the bathroom multiple times during the night. So urinary issues can be irritative to the bladder due to irritative reasons to the bladder, obstructive such as BPH or prostate issues, retentive when your bladder is relaxed and unable to actually to have a good urinary stream and can lead to dribbling. Most patients with PD are because of effects of control of urination. So there's usually frequency with urgency. And there has been noted that some patients that have undergone DBS have noticed improvement in their nocturnal urinary issues. So usually when we hear about nocturia, when there's increased frequency of urination during night, we kind of review medications, review other medical conditions. Are you on a fluid pill, or can we treat your hypertension with other medications that don't cause you to have increased urination? We ask that the patients limit fluid intake 2 to 3 hours prior to bedtime. So try to get as much of fluid that you need earlier on in the day. Right before you get into bed, empty your bladder. Sometimes we consider medications to help with irritative bladder. Some of these do have side effects, so we have to weigh those carefully. When we need help, we ask our urology colleagues to help with usually with obstruction or retention. And then if we are having issues and we're not able to kind of control with the frequency or urgency to prevent any injuries, sometimes we ask for a bedside urinal or a commode just to make that trek to the bathroom less bothersome. Nighttime hallucinations, psychosis, and confusion can also lead to sleep disturbances. Usually it's seen as Parkinson's progresses and there's cognitive impairment as well as dopaminergic medications. Vision changes can also lead to nighttime hallucinations, and other sleep disorders, as we've talked about. Impairing adequate sleep can lead to increased frequency of hallucinations. It can range from just ideas of presence. I feel like somebody's there, but when I look, there's nobody there, to a very detailed and often frightening visual hallucination. Sometimes it's not actually seeing somebody, but it's is a paranoid delusion that may make it hard for us to kind of turn off our brain and fall asleep. So usually we'll go over your medications, we simplify it, we make sure there's no other sleep disorders going on. We try to provide a consistent and familiar sleep environment. Sometimes we do have to resort to the use of atypical antipsychotics to help with those frightening hallucinations. So this is a slide to kind of not just is it Parkinson's disease, but sometimes it's the medications that can interact with our sleep. So dopamine in the form of levodopa, carbidopa, Sinemet, excessive amounts of it can lead to excessive daytime somnolence. So usually oversimplification or simplification of your medication regimen can improve daytime somnolence. Dopamine agonists can also cause excess daytime somnolence, usually severe in the form of sleep attacks. Vivid dreams and nightmares are reported on patients with dopamine agonists and hallucinations. MAO-B inhibitors do have a stimulating property, so can be associated with some insomnia. Amantadine, usually given for dyskinesias, has a stimulating property as well and can be related to insomnia and hallucinations. Just because I'm going over this doesn't mean that you'll have these side effects or symptoms because of these medications, but they can be contributing to them. So that's something to keep at the back of our minds as we evaluate patients. Adequate sleep hygiene. So while I was preparing this slide, so I have a 1-year-old daughter who I'm trying to sleep train or tried to sleep train. And while I was going through the slide, I was like, well, sounds like something I did with my daughter. So I guess no matter how old you are, sleep hygiene is important. It's important to set a schedule and keep a schedule. So kind of falling asleep at the same time every day, waking up at the same time every day. It can be hard if we're working, I'm trying to relax on the weekends, but the more that we are able to stick with the schedule, the better it is. Follow a bedtime routine. Wash your face, brush your teeth, take any medications that you need to before falling asleep. That way your body, your mind, your body knows that, hey, sleep's around the corner. Limit naps during the day. So naps between 15 to 20 minutes can help with restoration during the day, kind of gives that boost during the day. Try to limit any naps, so no naps after 2 or 3 p.m. Spend time outside in natural light, so get the stimulation of that light during the day. Exercise during the day. Avoid caffeine within 4 to 6 hours prior to bedtime. Avoid large meals 2 to 3 hours before bedtime. Limit screen time, iPad, computer, cell phone use, or I guess YouTube use or Instagram use, 1 to 2 hours prior to bed. Relaxation, meditation techniques can help. Regulate bedroom light and temperature at night. Make sure it's not too warm, not too cold. Reserve your bed mainly for sleep. Get into bed when you are sleepy. If you notice that you're trying to fall asleep, you're doing everything that you can to fall asleep, and it's been 20 minutes, try getting out of bed. Do some light reading, meditation, sedentary activity. Don't turn on the TV and start watching the news. Anything in the low light that kind of relaxes your mind a little bit, and then try again. This is a picture of a person not adequately following sleep hygiene. So we see that not only chocolate for caffeine, there's a big box of pizza that's partially eaten, a computer and cell phone at the bed. So I guess this is a picture trying to say not what to do. So what are the benefits of good quality sleep? Not only is it important that we feel awake and refreshed in the mornings, but we know that if you have good quality sleep, it improves cognition and energy levels. There's decreased risk of accidents, decreased risk of hallucinations. There's improvement in reaction time, better judgment. Patients with Parkinson's have also noted improvement in akinesia, so decreased movement. So they notice that their motor symptoms, as well as their non-motor symptoms, are better in the morning after a good night's rest. And remember, it's not just the number of hours we sleep, it's the quality of sleep we get as well. So, in summary, it is important to get a good night's rest. We all know that. Several factors can contribute to sleep issues in Parkinson's disease. Sometimes it's just normal aging. It can be due to motor and non-motor symptoms of PD, poor sleep hygiene, sometimes related to medications, or maybe medical issues unrelated to Parkinson's. Sleep problems are oftentimes underreported to health professionals, and proper treatment of sleep dysfunction can have big benefits on the quality of life. Thank you, guys. I think.
Okay. Okay, thank you, Dr. Dhillon. So right now we are going to take kind of a commercial break so that we can get reset for the question and answer period. Okay, welcome back, everyone. We are going to now go through the questions that you all submitted during the throughout the course of the live session. So Dr. Dhillon will take her time to answer these. I've got questions that are been written, and I'm getting more text to me as you all are still submitting them. So we're going to try to get through as many of them as possible. Okay, so we'll start with this first one. Are there any biomarkers that are used or are under study to replace or add to the effectiveness of sleep studies for determining if you have a sleep issue?
That's a good question. Unfortunately, there's nothing in my knowledge that I know of that is a biomarker for poor sleep. Again, if you notice that you're having symptoms of poor sleep or sleep apnea, some other biomarkers could be daytime somnolence, dry mouth, increased blood pressure, as well as type 2 diabetes, heart arrhythmias that you didn't have prior to sleep issues that you've known about. There are something that I've recently read about, skin biopsies for alpha-synuclein, but again, that doesn't necessarily correlate with sleep issues.
Okay, I understand avoiding caffeine, but can you comment? I can't even read my own handwriting. I understand. Yeah, I understand avoiding caffeine, but can you comment more on large meals?
Okay, that's also a great question. So I had said avoid large meals 2 to 3 hours before sleep. Large meals not only will it can lead to issues once we lay down, such as GERD, reflux, but it also can lead to drops in blood pressure, changes in our glucose homeostasis, which can lead to worsening in our sleep.
Okay. How do you know, or when should you see a sleep specialist?
That's a good question as well. So usually if a patient asks me this question, it's like, you must have concerns that you're asking me this question. So that's reason enough for a red flag in my mind that you should see a sleep specialist. If you feel like you yourself aren't getting adequate sleep, you're having some of those symptoms that I reported of poor sleep, worsening cognition, daytime somnolence, just waking up fatigued, that's reason enough, I think, to either discuss your sleep issues with your neurologist or maybe seek the help with a sleep specialist. I hope I answered that.
Okay. Any thought on why REM sleep disorder is related to Parkinson's disease?
So that is a good question. We know that up to 60% of patients or even more with Parkinson's disease or alpha-synucleinopathies have a REM behavioral disorder. And unfortunately, there's no clear-cut reason, but it's associated with alpha-synucleinopathy. So it's thought that the abnormal protein clusteration that also occurs in the sleep centers that control REM behavioral, and then kind of progresses to the basal ganglia that controls our motor aspect of Parkinson's disease. So it's associated with alpha-synucleinopathies, but not a clear-cut, exact link that we know of.
Okay. So a lot of talk about sleep apnea, and people had several questions related to sleep apnea. And so can you comment on why or how is sleep apnea so how dangerous is it? So should a person seek treatment, and why is it so important?
So yes, sleep apnea is dangerous because not only is it associated with poor quality sleep, but it's also associated with increased strokes and heart attacks that we know of. And so I would say it's dangerous enough for us to have management for it and adequate treatment. And it's usually diagnosed with a sleep study, ensuring with the help of all those. So during a sleep study, you usually either nowadays you can have the option of having it at home or at a sleep lab. So I don't read these studies, but you go to a sleep lab, you try to fall asleep, and during that you have an EEG monitor, pulse ox monitor, heart rate, as well as a blood pressure cuff and a breathing belt. And so with sleep apnea, what we realize is there's decrease in the blood oxygen levels as during certain stages of sleep. And with the breathing belt, we can find out what during inhalation, exhalation, as well as the airflow monitor. So that's how sleep apnea is diagnosed. And it is unfortunately dangerous because it is associated with increased risk of stroke and heart attacks.
Okay. You mentioned during your presentation adjusting the mattress if REM sleep disorder, if you have REM sleep disorder. This person says, I've changed my mattress angle for blood pressure issues. So can you comment on that?
Okay, so for REM behavioral disorder, so injury is what we try to avoid. And I discussed changing the mattress in terms of making sure that you're not on a raised platform, but maybe changing the mattress to the floor. We can continue to have the angle. I'm sure it's related to increase in blood pressure when you lay supine, so totally flat. So you can still have that wedge when you're on the floor. It's just ensuring that if you do have REM behavioral disorder, you don't fall out of bed and injure yourself as you fall.
Okay, great. Thank you. This question is from someone regarding restless leg syndrome, and they said that they thought that leg jerking was restless leg syndrome. Is that something different, or can maybe you just go over again what restless leg syndrome is?
Sure. So restless leg syndrome is a subjective complaint. If I was to look at somebody, I couldn't tell them what they're feeling subjectively. Remember, it's 4 cardinal features. So there's an urge to move your legs, activity helps, resting, unfortunately brings upon the symptoms, and it's usually seen in the evening. So it's more of a subjective complaint that we have. Whereas jerking of the legs, if you're not doing it voluntarily, it's involuntarily, and during sleep, that's usually associated with periodic limb movements of sleep. Usually a sleep study, and usually a patient, if you're aware of your leg jerking, it's not PLMS or periodic limb movements of sleep.
And what medications might be associated with RLS? I know you talked a little bit about that, but maybe in more detail. I know there are lots of commercials out there about what you take for restless leg syndrome, so maybe you can comment on that.
Okay, so medications associated with RLS, we through a questionnaire, we'll ask how much caffeine you take in a day. Sometimes antidepressants are associated with restless legs, so something a little bit stimulating. SSRIs, SNRIs, even TCAs, or certain groups of antidepressants that are associated with restless legs, as well as sometimes antipsychotics and anti-nausea medications, as well as some over-the-counter medications for cold and allergies that contain Benadryl or antihistaminics.
Okay. You all submitted lots of questions about melatonin. So I've kind of condensed a bunch of questions down to this one card. What about melatonin? But specifically, what's better, gummies versus pills, controlled release versus regular? And then I know you mentioned kind of dosage and where that should be, but what is kind of the max dose or the starting dose that someone should consider?
Sounds good. So melatonin, yes, it comes in a variety of flavors and packages, gummies versus pills. Unfortunately, not all of it is tested by the FDA, so I can't really comment on which one would be better. There are certain companies that I know of, not personally, but have used that I like Nature Made. Controlled release versus regular release. The reason why controlled release is out there is because we know that melatonin kind of peaks towards 12 p.m. midnight or 1 a.m. So rather than taking it at 8 p.m. kind of as the sun comes down, it kind of causes that controlled release. However, I will say I myself have tried melatonin controlled release, but it gave me a hangover effect. So sometimes it's just trial and error and see what works well for you. I had one patient who would do immediate release as well as a controlled release. The max, usually the starting dose I say is, I always tell my patients, you start low and go slow. And so I usually say start at 3, usually 3 milligrams or 5 milligrams. Around some patients, 30 minutes before bedtime, if you want to try to stimulate with our natural responses, then kind of at sundown. But again, sundown changes from summer to winter, and just keep that in mind as the seasons change as well.
There are questions related to levodopa specifically, and it being kind of stimulating for some people, maybe less stimulating for other people. So the question I've kind of condensed down to how close to bedtime should levodopa be taken, or should you avoid it around bedtime?
Okay, good question. So depending on why you're taking levodopa prior to bedtime is important as well. So if you're taking it for a nocturnal off, it's important to kind of time that. I usually get up around, midnight to go to the bathroom. That's why, and I have issues. So I take it prior to going to sleep. I think this is more of a trial and error. Everybody responds to levodopa differently personally, but I would recommend, some patients take it right prior to going to sleep, so that way it's in their system when they wake up at 2 or 3 a.m. But if it is stimulating, I would first try, an hour before, an hour and a half for a few days, and then kind of transition over and see what works best for you.
Right. So switching, this is kind of a different topic related to deep brain stimulation. And the question was, does deep brain stimulation have any impact on sleep? Would turning off the stimulator benefit or impact sleep in any way?
Good. So we know that deep brain stimulation in the field of neurology has not only been approved for Parkinson's, but also for essential tremor. For patients with essential tremor, I usually say you can turn off your DBS at night, but usually with Parkinson's, we recommend keeping the stimulator on because we know that it's not only important for motor, but also in some of the non-motor issues that are associated with Parkinson's, such as kind of alluded to, kind of the urinary complaints that we've seen at night. So I do believe that patients after having DBS, through my experience, have reported better subjective sleep stuff.
This individual is taking Klonopin, which he says works great, but are there any long-term side effects to taking that particular medication?
Okay. So clonazepam, I'm guessing you're taking for REM behavioral disorder. Clonazepam is a benzodiazepine medication, so it acts on the same receptors of the brain as alcohol does. Long-term side effects of benzodiazepine use is dependency, as well as kind of a tolerability. So may need increased doses as your disease progresses. And the other thing is it can affect cognition with long-term use. However, I would kind of beg to differ that clonazepam helping possibly your REM behavioral disorder is kind of more important to ensuring adequate sleep. Another thing is making sure you don't withdraw or cold turkey on clonazepam, because that could lead to devastating consequences such as withdrawal seizures.
This sounds like it's a little bit of an issue going, debate at home about whether or not weight affects sleep. So she says, or actually this was anonymous, says that they are a little fluffier than maybe they want to be. And the daughter thinks that weight is affecting the sleep issues. Can you comment on whether or not that's the case?
Yes. So weight does affect sleep. The one way that we know of is increased weight increases your risk of obstructive sleep apnea because of the increased amount of fat as well as subcutaneous tissue kind of around our neck and throat areas. So it can increase the prevalence of sleep apnea in patients that are overweight.
Okay, we have a few more questions here. I usually start dreaming immediately, even before I'm fully asleep. I can actually have a complete dream in a few minutes. For instance, if I doze off while reading or watching television. Is this anything I should be worried about? And by the way, I also have very vivid dreams and tend to act them out and talk in my sleep.
So having dreams or dreamlike states, it's important to, especially if you're not already asleep. So REM usually happens during sleep. And so acting out or seeing your dreams may actually be something called hypnagogic, going to sleep hallucinations, which can occur. And if you are falling asleep that readily while you're watching TV or sitting on the couch, does raise a question of increased daytime somnolence and how adequate of sleep you are getting at night. Whether REM behavioral disorder, given that you have vivid dreams and acting out your dreams, is actually impacting your overall quality of nighttime sleep. I do suggest talking to your neurologist about your above symptoms and hopefully getting them addressed.
Okay. Let's see. I have obstructive sleep apnea and use the CPAP. I take rasagiline and losartan before retiring before the night. I fall asleep easily, but almost every night I wake up an hour and a half after falling asleep and sometimes experience difficulty then getting back to sleep. Is this common, and is there anything else that could be done to remedy that?
Okay, good question. So we know that patients with Parkinson's have increased nocturnal arousals as well as difficulty falling back asleep. I think I'm glad to hear that the CPAP is working well for you. First, talk to your sleep specialist to make sure your machine numbers are well, your compliance is great, and then that also the airway, the flow of the device is adequate during the night. Other than that, kind of going over your medications with your neurologist to ensure there's nothing else confounding it. Have a questionnaire, sometimes talking whether anxiety, depression is also alluding to it. Do you have any other stimulating medications on board? And kind of going over your sleep hygiene with your neurologist as well.
Okay, I think this is a question that a number of people is burning on the mind of a number of people, but maybe only one person thought to ask, which is it okay to have a glass of wine to wind down at night before going to bed?
So again, the reason why we talk about sleep, it's all about quality of life, right? So if I say have that glass of wine if it helps you relax and go to sleep, I don't think there's an issue with that.
She said glass, not bottle. So just keep that in mind. Is there a reason why some people fall asleep more easily, but then wake up and can't go back to sleep, while others have trouble falling asleep, but once asleep, they are incredibly hard to awake?
The difference between me and my husband. Unfortunately, I think it's just, I don't think there's a right answer for that. I think it's just how we're built. You can ask a number of patients. I've always been a poor sleeper. I've always been, one of those patients that really hard to awake. I can sleep through a hurricane. And I think it's just kind of what we were brought up as and how our internal architecture is.
Okay. Any suggestions on how to go back to sleep when waking up in the middle of the night, which then kind of ties to maybe what I'll consider No, I'll let you answer that question.
Okay.
And then as I reread that question, I realized these are a little bit different. One is
Okay.
getting back to sleep and other is
Okay.
preparing.
So I guess my question would be, why are you waking up, right? Is it because your sleep debt is completed, because you may be taking naps during the day and so your nocturnal sleep isn't as well as needed? Or is it because you're waking up to use the restroom? So addressing the reason why you're waking up. And if it's just a spontaneous wake up, kind of going over those sleep hygiene rules of kind of laying in bed, meditating, calming the brain. If it is related to insomnia, anxiety, or depression, that needs to be addressed, likely by your neurologist or sleep specialist. But I would recommend anything that you can do in the meantime, such as cognitive behavioral therapy, meditation, would help.
Okay. I'm trying to get clarification on one of the questions that was submitted. And if I don't, that's okay. We'll just, we will go to this question, and this may or may not be the last one.
Okay.
This comment is, I wonder if Dr. Dhillon has any comments on biofeedback practices such as monitoring heart rate coherence to calm the mind as a way to prepare for sleeping.
Oh.
So this is maybe not how to get back to sleep, but in kind of preparing to go to bed.
Okay. Good question. I do not have personal experience on that. I think anything, if it's part of your routine, keep it up. If it isn't interfering with your ability to fall asleep or relax prior to sleep, I recommend patients do whatever they can that kind of gets you to that kind of drowsiness state. But if it is something that you're realizing that you're fixating on the numbers, my heart rate's this level, it should be this way, then I recommend not doing it. But however, if it's something that you're like, kind of helping yourself zen out prior to sleep, then go for it.
Okay. All right. And then, okay, so this is the last question, and I did get some clarification. I'm not sure that I'm going to do this question justice, but can taking 5-HTP help with sleep? Does it interact with any other medications?
Okay. So,
and this is that was the clarification on HTP,
okay,
in case I was not familiar with it. But.
Yeah.
Okay. Okay.
So 5-HTP, it can help sleep.
Would you describe what 5-HTP is?
5-HTP is a precursor or tryptophan of serotonin, which can help with melatonin. So what's it called, Handmaid's Tale or something? Drink a glass of milk before you go to sleep, a warm glass of milk. So the reason why we say that is because milk has tryptophan, and which leads to serotonin, may help with sleep induction. I don't think it's something that would harm you. If it benefits, then great. If it doesn't, then it doesn't. Again, I don't think there's anything out there that goes against or for it. I say try it out, and if it doesn't help, then it doesn't help. But if it does, then great.
Okay, so that we have successfully made it through all of the questions that you submitted in the time that we had. So that is going to wrap up our question and answer session. Thanks to all of you who submitted great questions. Next up is the Movement Lab with Rita Upadhyaya. And she is, and so we are going to take a brief break so that we can go to that. If you're not able to stick around and move with us, I do want to just take a minute to thank you all for joining us, and to thank again our sponsors for their generous support of our educational programs, as well as Dr. Dhillon for her time. The session will be available online in the coming weeks, so don't forget to check out our website for the latest for this session, and also the latest in-person and online exercise sessions that HAPS is offering, as well as upcoming educational programs, including the July and August session of the summer lecture series and our biennial educational symposium, which will be held in September. So now we are going to jump over to Rita Upadhyaya, who will lead us in yoga. Rita is a certified yoga instructor who's been practicing yoga for decades. She is a wonderful part of the HAPS family and currently teaches a very popular online yoga class for HAPS, and soon will be resuming her in-person HAPS yoga class out in the Conroe area. So now we're going to go to Rita. Thank you.
Hello there. In this video, I would like to introduce you to some fun movements and sun salutations. Sun salutations are made up of 12 different yoga poses. When they are synchronized and repeated multiple times, they become a set. When practiced, you will be energized and bring clarity to your mind. It is important to practice these steps each morning. Remember, use your breath to your advantage. This is crucial in yoga. I will also share a breathing technique in this video. It is called Shitali, which leads to a cooling of the entire body from within. Use this technique as needed in rounds of 3s or 5s. Enjoy. Let's begin with some gentle movements. Here are the 12 yoga poses to practice sun salutations. Please observe or follow along with me. Mountain pose. Extended arms up towards the sky. Slight back bend. Forward bend. Step back. Step back in plank pose. Knees down, child's pose. Chest and chin to the ground. Low cobra. High cobra up dog. Downward facing dog. Step forward. Forward bend. Open arms. Stand up. slight back bend into standing prayer pose. Prepare for sun salutations. Have your chair ready. Let's have some fun movements together. Yoga is part of a larger framework, which includes branches of philosophy and selfless service. Physical postures addresses strength, flexibility, balance, and the mind-body connection. Breathing practices and meditation helps to develop greater self-awareness. Yoga is for everyone. Remember to practice within your limits. Use supports such as chairs, walls, straps, and bolsters to enhance balance and your range of motion. Using music helps with coordination, and in my personal experience, yoga brings about a calming effect. Here are some steps to follow the breathing technique called Shitali, which means the cooling of breath. Get comfortable in a seated posture. Relax your shoulders away from your ears. Lengthen your spine, soften your belly. Ensure your chin is parallel to the floor. Here you will inhale with your mouth open. Get your tongue out with the rolled edges to the center. Draw the air in your mouth, then bring your tongue in and quickly close your mouth. Then exhale fully through your nose. Let's repeat. Tongue out, roll the edges, and close your mouth. Now exhale the heat out from your nose. Pause, then continue. Enjoy the cooling of your mouth. Repeat as you find necessary. Here is another way to cool if you can't roll the edges of your tongue. Purse your lips and rest your tongue behind your lower teeth. Inhale through the mouth, close your mouth, and then exhale the heat out from your nose. Simply continue and feel the cooling effect. Use this breathing technique when necessary. I hope you make this yoga practice a part of your routine. Namaste.
Thank you, Rita. Well, that is a wrap for the 2021 June session of the HAPS Summer Lecture Series. We look forward to seeing you back here online in July for our next summer session. As a reminder, HAPS is always here to help. Please reach out and have a great day.